Welcome to today's deep dive. And I have a confession to make to you right out of the gate.
No.
Yeah, I am currently staring at a massive and honestly incredibly intimidating stack of lecture audio.
Let me guess.
It's all about medication administration. And honestly, stepping into the shoes of a nursing student for this deep dive, I am feeling a little overwhelmed
I can imagine.
because there are just so many rules, so many steps, and the stakes just seem impossibly high. If you are listening to this right now and you work in healthcare or you're studying a jury, you probably know exactly the feeling I'm talking about.
It is entirely normal to feel that way. In fact, if you aren't feeling a healthy amount of respect for the process of medication administration, I would be worried.
That's a relief to hear, actually.
But you don't have to tackle this alone. Think of me as your veteran nursing instructor today. We are going to walk through this material together, not just as abstract concepts, but as the practical reality of the floor.
I appreciate that so much. Because the mission for our deep dive today is mastering what are known as the 7 rights of medication administration, along with some truly essential bedside safety protocols.
Right.
And from going through these sources, it is abundantly clear that these aren't just things you memorize to pass a pharmacology exam. These are the literal safeguards that protect a patient's life, and at the same time protect a nurse's hard-earned license.
That is the perfect way to frame it. Every single protocol we're going to discuss exists because historically a preventable event caused harm to a patient.
Wow, yeah.
Medication errors are almost always preventable. They usually stem from a moment of distraction or simply a lack of knowledge about the specific drug being given. We are dealing with potent chemicals that alter human physiology, so the margin for error is incredibly thin.
Okay, let's unpack this, because where do we even begin to build that safety net? The source material put a huge emphasis on this overarching philosophy of safety before we even get to the specific 7 rights. It talks about building an automatic reflex.
The absolute foundation is something called the 3 checks.
The 3 check.
Exactly. Before you do anything else, before you even think about the patient's room, you have to internalize this golden rule. You are going to check the medication against the patient's orders 3 separate times.
Okay, so what's the first one?
First, you check it before pulling the medication from the automated dispensing system.
Right.
Second, you check it immediately after pulling it while you are still standing right there at that dispenser.
So you haven't even walked away yet.
Correct. And third, you check it again right at the patient's bedside before you actually administer it.
So it's not just a repetitive checklist. It's about building an automatic habit to combat fatigue.
Precisely. When you are 10 hours into a grueling shift, your muscle memory takes over and forces you to verify the data.
And that brings us right into the first major safeguard, verifying you have the right patient. The standard protocol here is using 2 identifiers, usually the name and the date of birth.
Yes, and the execution of this is what matters. You don't just walk into a room, glance at their armband, and nod to yourself.
Which I imagine is tempting when you're busy.
Oh, definitely. But you actually ask the patient to state their name and date of birth out loud. Then you match what they're saying to what is printed on their armband and what is active in your computerized scanning system.
You're triangulating the data.
You are.
The sources were incredibly strict on a couple of common pitfalls here. For anyone listening who might be tempted to use shorthand, never use a room number to identify a patient.
Never.
The sources were clear that saying things like the guy in 402 is a catastrophic error waiting to happen.
Because patients are transferred, discharged, and move between rooms constantly, room 402 could have a completely different patient in it after your lunch break.
That is terrifying to think about.
And here is another practical bedside reality you have to prepare for. You will eventually have patients with the exact same name or incredibly similar names on the exact same unit.
The John Smith problem.
The John Smith problem is a massive liability.
So how do you handle that operationally? You can't just rely on hoping you remember which John Smith is which.
When that happens, the protocol is to use name alert signs. You place these in the electronic medical record on the physical chart and even physically in the room.
Okay.
It actively warns every single clinician stepping into that space, whether it's a nurse, a doctor, or a respiratory therapist, to stop and double-check who they are treating before doing anything.
That makes a lot of sense. It forces a physical pause in the workflow.
Yeah.
Now let's talk about the medication itself.
Yeah.
Because there was a communication hack in the audio that I thought was brilliant.
Which one?
It advised nurses to verbally tell the patient what medication they are scanning before physically popping the pill out of the foil packaging or opening the container.
Ah, yes. What's fascinating here is how much of an impact that simple communication shift has on error prevention. Consider what happens if you stand at the bedside, stand 5 different blister packs, pop them all into a little plastic cup, hand it to the patient and say, "Here are your morning meds."
The immediate response from the patient is usually, "What am I taking?"
Right.
And if one of those was loaded incorrectly in the pharmacy, or you accidentally pulled the wrong vial from the drawer, the patient might look at the cup and say, "Wait, I don't take a sleeping pill."
Exactly. But by then, they're all mixed together in the cup. You've created a completely unnecessary puzzle.
And you have to figure out which white tablet is the blood pressure med and which is the sleep aid.
And you've potentially wasted expensive medication. But if you hold up the package and say, "I am scanning your blood pressure medication," and the patient replies, "Wait, my cardiologist took me off that yesterday,"
You catch the discrepancy before the package is even opened.
you are using the patient as an active participant in their own safety check.
I love that. And the rule is also to return any medication where the label has peeled off or is unreadable, right?
Absolutely. Guessing is never an option, which flows naturally into verifying the dose. This isn't just blindly trusting whatever pops out of the dispensing machine.
It means utilizing clinical judgment to ensure the dose makes physiological sense for that specific patient's parameters, like their age and their weight.
This is where critical thinking is paramount. If you are looking at an order for a pediatric patient or an adult on a powerful blood thinner, that dose is highly dependent on their specific body weight.
So if the order says 300 instead of 30, because someone accidentally added a 0 during data entry, your intuition has to catch that anomaly.
Yes. You also have to use standard, precise measuring devices. And you must always question any abrupt massive increases or decreases in a patient's standard dosage.
So getting the exact milligram amount right is critical, but the math doesn't mean much if it enters the body through the wrong tissue. And that leads us to the route of administration.
It's a forthright.
And the big takeaway from the sources was that the physical equipment we use is actually engineered as a built-in safety check.
The equipment is designed to protect you from yourself. For instance, if you are giving a liquid medication enterally, you use an oral syringe which has a smooth, blunt tip. But if you are administering medication into an IV line, you use a syringe with a luer lock, which is threaded and screws securely onto the IV tubing.
It's engineered friction.
Yeah.
The different designs exist, so you physically cannot attach an oral syringe to an IV line.
Because if you inject a medication meant for the acidic environment of the stomach directly into a patient's bloodstream, the results can be catastrophic.
It's a devastating, often fatal error. The physical incompatibility of the syringes is a hard stop meant to interrupt a lapse in concentration.
Exactly.
Let's shift to timing, because this is where I start to see the friction between the ideal rules and the reality of a hospital floor. If I am a nurse with 7 patients who all have medications scheduled for 8 a.m., I physically cannot be in 7 different rooms at exactly 8 a.m. How strict are these timing rules in practice?
That is the daily reality of floor nursing. Facility policies usually account for this by establishing a 1-hour window for routine daily medications. You can administer an 8 a.m. vitamin or a daily cholesterol pill anytime between 7 a.m. and 9 a.m., and it is considered legally and clinically on time. However, you must understand that critical medications absolutely do not have that kind of flexibility.
We're talking about things like antibiotics, where timing is a biological necessity, not just an administrative schedule.
Exactly. Antibiotics often have a strict 30-minute window. You aren't just checking off a task list, you are actively trying to maintain a very specific therapeutic level of that drug in the bloodstream to fight off an infection.
Because if you are late, the drug concentration drops and the bacteria can multiply.
Right. And we have to clarify the terminology providers use here because it dictates the timing. An order that says every 8 hours is vastly different from an order that says 3 times a day.
Because every 8 hours means a strict mathematical round-the-clock interval. 6 a.m., 2 p.m., 10 p.m. The spacing is required to maintain that chemical shield in the blood.
Correct. Whereas 3 times a day typically just means the patient needs 3 doses spaced out roughly during their normal waking hours, perhaps timed with their breakfast, lunch, and dinner. Misinterpreting those instructions compromises the entire treatment plan.
Okay, and once you give that properly timed medication, you have to document it. The golden rule in the sources was immediate real-time documentation at the bedside using the computerized system.
Documentation is not an administrative chore you do at the end of your shift. It is an intrinsic part of the administration process itself.
If you don't document it the second it happens, another nurse covering your break might look at the chart, assume the medication was missed, and administer a lethal double dose.
Yes. And documentation includes both pre-assessments and post-assessments. If you are giving a potent heart medication like digoxin, you have to physically check the patient's heart rate right before you give it, because the computer system will force you to input that data before it unlocks the order.
And for post-assessments, consider intravenous pain medication. Your responsibility doesn't end when the plunger is pushed. You are clinically required to follow up, usually within 30 minutes, to assess the patient's current pain level.
Right, you have to document whether the intervention actually achieved its intended effect.
Okay, so the final right in our core list
Yeah.
is the indication or the reason the patient is receiving the drug. There was a story in the lecture audio that perfectly illustrated this. A nurse was doing a routine medication reconciliation for an 80-year-old patient and noticed she was still taking a specific menopause medication.
And when the nurse simply asked why she was taking it, the patient revealed her doctor put her on it when she was 40. And she just
Yeah.
kept taking it out of habit for 4 straight decades.
40 years. Just because nobody stopped to ask, what is the clinical indication for this drug right now? That just blew my mind.
It highlights the danger of blindly following a list without applying clinical judgment. Knowing the indication prevents massive systemic errors. Let's look at a common scenario. A physician writes an order for Tylenol, but specifically dictates it is strictly for a fever greater than 100.6. What is your clinical move if that same patient rings a call bell and complains of a mild headache?
Well, based on the strict rules of indication, I cannot give them that specific Tylenol order for the headache, even though Tylenol is universally known to treat headaches.
Because the written, legally binding indication in the chart is exclusively for fever.
Right. I would have to contact the provider for a completely new separate order for mild pain.
You are protecting the patient from unapproved treatment, and you are protecting your license by adhering strictly to the indicated use defined in the medical record.
Here's where it gets really interesting for me, though. We've laid out these perfect sterile rules. But how does this actually play out in the chaos of a real hospital floor? What happens when you aren't calmly reading a computer screen, but you're getting complex orders shouted at you over the phone by a rushed doctor in the middle of an emergency?
Telephone orders are a reality of medicine, and they carry an incredibly high risk of miscommunication. This is where the readback method is an absolute non-negotiable requirement.
The instructor in the audio was emphatic about the logistics of this. You absolutely cannot try to chart live in the electronic medical record while you are on the phone with a doctor. The system is too slow, there are too many click-through menus, and a rushed physician will not wait for you to navigate it.
They will hang up on you. So you must have scratch paper and a pen on your person at all times. When you receive a phone order, you write down the current time and you transcribe exactly what the doctor is ordering. Then before that call disconnects, you read it back to them in its entirety.
Like, okay, doctor, let me read this back so I have absolute confirmation. You are ordering a stat chest x-ray and Tylenol 500 milligrams by mouth every 6 hours for a fever greater than 100.6.
It forces the physician to actually listen to what they just ordered out loud. It confirms your transcription is flawless. And often hearing it repeated prompts the doctor to realize they forgot a component like ordering a saline drip to accompany the medication.
And only after that phone call ends and the order is confirmed, do you input the data into the official electronic medical record for the provider to digitally sign later.
Exactly.
What about the human element on the patient's side? Because patients aren't just passive receptacles for medication, they have the absolute right to refuse care.
This raises an important point about the nurse's role as a patient educator. When a patient refuses a medication, your job is not to bully them, coerce them, or force compliance. Your job is to educate them on the clinical necessity.
So it's about shifting from an authoritarian approach to a collaborative one.
Yeah.
Saying, I understand you don't want this antibiotic, but here is exactly why the doctor ordered it and what it's actively doing to fight your infection.
You are empowering them to make an educated decision about their own body. If they still refuse after being fully informed, you respect that fundamental right. You document the refusal meticulously, and you are obligated to notify the charge nurse and the prescribing provider so they are immediately aware the treatment plan has been altered.
While we are on the topic of assessing the patient's needs, the sources brought up allergies in a way I hadn't considered. Obviously, checking for medication allergies is standard, but they heavily emphasized environmental allergies. There was an anecdote about a nursing student who had a severe respiratory reaction in the industrial bleach that the hospital housekeeping staff used.
It's a vital reminder that allergies aren't just limited to penicillin or latex. If you have a patient with a severe environmental allergy to bleach or certain chemical solvents and housekeeping comes in to mop the floor, that patient could easily go into sudden respiratory distress.
Wow.
You are responsible for assessing the entire environment of care, not just what's inside the pill cup.
That requires a level of situational awareness that is really intense. All right, let's pivot to the highest stakes of all. The source has dedicated a significant amount of time to high-alert medications.
This requires a fundamental shift in how a clinician approaches the administration task. We are talking about drugs where the margin for error is razor thin. Insulin, heparin, which is a powerful anticoagulant, critical care intravenous drips.
The heavy hitters.
These are medications that can cause devastating, irreversible harm or even death if the calculation is off by a fraction of a milliliter.
And because of that extreme risk, they require a second nurse to physically verify the medication, the calculation and the dose before you are allowed to administer it. But the instructor gave a stark warning to the listener here. Never ever blindly trust the other nurse, even if they are your most experienced colleague.
It is human nature to want to trust your team. If a colleague you respect says, "I just pulled 10 units of regular insulin," the temptation is to simply believe them, sign off in the computer, and move on with your busy shift.
Which you cannot do.
You absolutely cannot. You must physically inspect the vial, verify the concentration, and look at the syringe yourself. And conversely, you must never authenticate a medication that someone else drew up out of your line of sight.
Because you're essentially blindly co-signing a mortgage. If they pulled the wrong med or calculated the dose incorrectly, it's your signature verifying the fatal dose. Your license is equally on the line. The audio also hammered home the absolute necessity of labeling everything immediately. If you draw up a high-alert medication at the nurse's station, you put a label on that syringe right then and there, with the drug name, the exact dose, the date, the time, and your initials.
If you do not label it and you set it down on a counter for even 10 seconds, it looks exactly like a standard syringe full of harmless saline flush. Another clinician could easily pick it up, assume it's a flush, and rapidly push a lethal dose of paralytic or insulin directly into a patient's IV line.
That's terrifying.
Labeling is not administrative busy work. It is a critical physical safety barrier.
Which brings us to the friction between human workflow and technological safeguards. We have all these incredible systems now. Barcode scanning for the patient's wristband, scanning the individual medication packages. We have smart 5E pumps equipped with built-in guardrails that have drug libraries programmed to physically stop you from infusing a medication at a dangerous rate.
But technology only functions if the human operator respects those guardrails. The system has to allow overrides for genuine life-and-death emergency situations where seconds matter. But overriding those safeguards casually because the scanner is glitching or you're in a hurry introduces profound danger.
The sources brought up the Vanderbilt nurse case, and it is a massive, chilling case study in what happens when alert fatigue beats a workaround. For those listening who aren't familiar, it is the ultimate tragedy of overriding a system. A nurse was trying to administer a routine anti-anxiety medication, but couldn't find it in the automated dispensing system.
Yes, I remember this case well.
So dealing with the pressure of a busy unit, she used an override function. She bypassed the barcode scanner entirely, and she accidentally pulled a powerful paralytic drug instead. She administered it to the patient. The patient was paralyzed while fully conscious, unable to breathe, and died. And the consequences were severe. The nurse lost her license and faced criminal charges.
It is the starkest reminder imaginable of why these protocols exist. Those annoying beeps, the endless pop-ups on the computer screen, the barcodes, scanning errors. It is so easy to view them as frustrating obstacles to your workflow. But they are the very safety net keeping your patient alive. When the machine stops you, you stop. You investigate the discrepancy. You do not blindly override the system to save 2 minutes.
So we have to talk about the reality that humans are fallible. Despite the 3 checks, despite the barcode scanners, eventually an error is going to happen. What is the actual strict protocol when a nurse realizes they just gave the wrong medication or the wrong dose?
The very first step, overriding every other instinct, is to immediately assess your patient. Check their vital signs. Evaluate their respiratory and cardiovascular status. Your patient's immediate physical safety and stability is priority 1.
So no panicking, no running out of the room to check the computer. The patient comes first.
Always. Step 2 is you notify your charge nurse and you notify the prescribing provider immediately. They need to know the exact nature of the error so they can quickly order any necessary medical interventions like an antidote or closer monitoring to counteract the mistake.
And then step 3 is the documentation process, which the source is highlighted as being very specific. You have to document the medication that was actually administered in the patient's electronic medical record, but you are absolutely not supposed to write phrases like given an error or mistake made in the chart itself.
That is correct. The electronic medical record is an objective, factual log of what physically happened to the patient. You chart the vital signs, you chart the specific drug and dose that was administered, and you chart the provider's response. But the subjective analysis of the mistake belongs in step 4.
Which is filing a separate official incident report with the facility's risk management department, right? And that incident report is where you detail the exact narrative, what was given, what the intended order was, and a full, honest explanation of why the system failed. Like the bins were loaded incorrectly in the pharmacy, or I bypassed the scanner due to a system outage.
The incident report is designed for root cause analysis. It is not about punishing the individual nurse. It is about finding the flaw in the systemic workflow so that exact same error never reaches another patient. But ethically and legally, you must report it immediately. Trying to conceal a medication error is the fastest way to permanently lose your license and, far more importantly, cost a patient their life.
This has been an incredibly deep, sobering look at what happens at the bedside. We've gone from the basic philosophy of the 3 checks and the 7 rights, all the way through the chaotic reality of phone orders, patient refusals, and the devastating consequences of alert fatigue and ignoring the guardrails. It really paints a vivid picture of this invisible, essential safety net that nurses weave around every single hospital bed on every single shift.
Yeah.
Thank you so much for guiding me and our listeners through the heavy realities of the floor today.
It has been my pleasure. And as we wrap up this deep dive, I want to leave you with something to ponder. We talked extensively about the friction between human error and technological safeguards.
Right.
As we move toward a healthcare future where artificial intelligence and advanced robotics handle more and more of the medication sorting, dispensing, and even administration, we have to ask ourselves something. Will the human element of the nurse increasingly be viewed as the primary vulnerability in a perfected digital system? Or when the machine inevitably makes a calculation error that no algorithm caught well, will the nurse's critical intuition, that inexplicable gut feeling that this dose just doesn't look right, become the very last, completely irreplaceable line of defense?
Wow, that is a fascinating thought to leave on. Thank you to everyone listening to this deep dive, whether you are prepping for your clinical rotations, trying to master pharmacology, or you just want to understand the incredible responsibility healthcare workers carry every time they step into a patient's room. Stay curious, respect the guardrails, and keep learning. We'll catch you next time.